Now, we just briefly mentioned ischemia and the ST segment depression and elevation, but I'd look a little more carefully into that. The factor that we are concerned with is the extent of ischemia in the left ventricle. Transmural ischemia occurs with absolute flow obstruction to the entire thickness of the ventricle and causes an ST elevation, whereas a subendocardial ischemia has only some flow obstruction, causing stable angina, unstable angina, and NSTEMI. And we can use the leads on the ECG to determine where the ischemia is. When the anterior wall of the left ventricle is ischemic, we see ST elevations in leads V1, V2, V3, and V4. When the lateral wall of the left ventricle is ischemic, we see ST elevations in the lateral leads, which are lead 1, AVL, V5, and V6. When the inferior wall of the left ventricle is ischemic, we see an ST elevation in leads 2, leads 3, and AVF. Now, by knowing which territory of the left ventricle is ischemic using the ECG, you can easily figure out which coronary artery is ischemic. Now, as a revision, the main coronary arteries include the right coronary artery and the left coronary artery, which has two branches, the left circumflex artery and the left anterior descending artery. So when you see an anterior wall MI, the ST elevations are in leads V1, V2, V3, and V4. The anterior wall is supplied by the left anterior descending, or LAD artery. When you see the ischemia in lateral walls, in leads 1, AVL, V5, and V6, it is supplied by the left circumflex artery, which is usually written as LCX. In the inferior wall, this includes leads 2, leads 3, and AVF. And this is supplied by the PDA, or the posterior descending artery. Usually, the ischemia is not in the PDA, but in the vessels that supply the PDA, such as the right coronary artery that supplies 90% of the patients, and the left circumflex artery, which supplies 10% of the patients. Now, sometimes you may see this kind of ECG, which involves a large territory, and it actually is as dangerous as it looks. This is a left main occlusion, which involves the LAD and the LCX. The hallmark is an ST elevation in the AVR lead, and everywhere else you see ST depressions, which may make you think that this is not an ST elevation MI, and that's why it's important to remember to look at the AVR. Now talking about NSTEMI. As the name suggests, non-ST elevation MI, you do not see ST elevations on an ECG, but there are some changes on the ECG that you do see, such as the ST depressions and T-wave inversions that can also be seen. You actually suspect it because the patient has an ischemic type of chest pain and T-wave inversions and ST depressions, but another way to make the diagnosis of an NSTEMI are the use of cardiac biomarkers like troponin I or troponin T. Hopefully, now you'll be able to identify ischemia on an ECG and what territory it involves.